Hi, good afternoon, everyone. My name is Corinne, and I'll be presenting to you today on depression, anxiety, and quality of life in post-concussion syndrome patients. So just a little bit of background. So what do we know about PCS and mental health? So the general prevalence of depression and post-concussion syndrome is around 14 to 29%, whereas for anxiety, it's around 23 to 25%. And of course, this varies due to different populations of PCS, different assessment measures, etc. And some common predictors of depression and PCS include female sex, younger age, increased number of previous concussions, and premorbid psychiatric illness, whereas some common predictors of anxiety and PCS include also female sex and also socioeconomic factors such as pre-injury unemployment. In terms of quality of life, this is an area that hasn't really been studied that much in post-concussion syndrome. The general consensus is that concussion patients with PCS do experience a poor quality of life. I tried to summarize some of the bigger studies that I found. So for example, this one was conducted in Western Sweden, where they showed that concussion patients with PCS had a lower quality of life compared to those without PCS, and also compared to general Dutch population norms. So the global aim of this project was to look at the intersection between depression, anxiety, and quality of life, and how this influences the trajectory of recovery in PCS patients. So there was three kind of sub-objectives. The first one was to look at the prevalence of symptoms of depression and anxiety in this population, and then to evaluate how depression and anxiety relate to age, sex, mechanism of concussion, and number of previous concussions. And then also to examine the quality of life in PCS patients with symptoms of depression and anxiety, which was measured by the WHO QOL-BREF, which is a quality of life assessment. So we started off with 846 patients that were diagnosed with post-concussion syndrome by Dr. Charles Tatter between 1997 and 2018. The criteria for PCS was any 3 PCS symptoms for 1 month or longer. We excluded patients who had extracranial injuries, had abnormal MRI or CT findings, that were involved in litigation, and also had other brain contusions, atrophies, etc. And then also patients, for them to be included in the study, could not have any other previous psychiatric illness besides depression or anxiety. So based on our inclusion criteria, we excluded 329 patients. And this is just a chart that shows our exclusions. So most of the exclusions were based on abnormal CT MRI. As you can see, that's the bulk of the patients. So we sent out a questionnaire package to the remaining patients. So there was 526 of them. This questionnaire package included the DAS-42, the WHO QOL-BREF, and also a questionnaire from the Canadian Concussion Centre. So just a little bit about the DAS-42. So the DAS-42 contains 42 questions. It's divided into 3 subscales, so depression, anxiety, and stress. So we were interested in depression and anxiety, and as you can see, a patient can score mild, moderate, severe, or extremely severe, and if they score normal on the DAS-42, they don't have symptoms of depression or anxiety according to this measure. It has good internal consistency and good reliability in clinical populations. And then a little bit about the WHO QOL-BREF. So it's a 26-question measurement of quality of life. The first 2 questions are general assessment of quality of life, and then the remaining 24 questions are divided into 4 domains. So physical health, psychological health, environment and social relationships. And then as you can see, there's different facets that each domain measures. So the higher the quality of life score, the more satisfied the patient is with their quality of life. So this is just a general kind of summary of the methods. So we started off with 846 patients. We sent a questionnaire package to 526. We received back 120 questionnaires. And then from those 120, we had to exclude 15 more. And then also 5 patients were excluded from the WHO QOL-BREF analysis due to incomplete questionnaires. And so the final patient population was 105 patients. So this is the demographics of the 105 patients that were included in the study. So as you can see here, there was more females than males. Most of the patients had a sports and recreation injury or a fall. That was their mechanism of the concussion. The patients either had So more patients had either 0 or no previous concussions, and the mean age in the respondents was 39 years old. And then also it's important to note, we asked the patients if they still felt they were experiencing PCS symptoms, and around 76% of them said they were. So this is a self-report. We also wanted to see how the respondent population compares to the total eligible population, so the initial 526 versus the 105 that responded. And so what I did was I did a chi-square analysis to look at the observed and expected frequencies based on eligible population proportions. And there was significant differences between the observed and expected frequencies for number of previous concussions, as well as cause of concussion, which means that the respondent population is not necessarily generalizable to the total eligible population. Okay, so getting into the results, so we had 37 patients who scored having symptoms of depression, anxiety, or both on the DAS-42. 68 patients scored normal. And then these two charts on the right here show you the distribution of symptom severity for depression and then symptom severity for anxiety. And then in terms of looking at the correlation between DAS-42 and age, sex, mechanism of injury, number of previous concussion, the only really significant results that were found was there was a small correlation between increased number of previous concussions and increased DAS depression and increased DAS anxiety score. So these are the results for the WHO QOL breath. So as you can see, I divided them by the 4 domains, so physical health, psychological health, social relationship, and environment domain. And then these are the mean scores for each domain according to sex, number of previous concussions, and cause of concussions. So the only differences that were significant in terms of the mean scores on the WHO QOL breath were for cause of concussion, and that was specifically in terms of social relationships and environment domain. And then when I went and did further tests, I saw that these differences were driven between sports and recreation and motor vehicle collisions. So patients with motor vehicle collisions reported poor quality of life in the social relationship domain. And then in terms of the environment domain, the statistically significant differences were driven between motor vehicle collision and object strike. So once again, patients with motor vehicle collisions in this domain reported poor quality of life compared to those who had a concussion from an object strike. And then here, I kind of summarized the relationship between the quality of life as measured by the WHO QOL breath and the DAS-42. So on the x-axis here, we have the total DAS score for each patient, and this was done through totaling the subscales, so anxiety, depression, and stress. And then on the y-axis, you have the mean WHO QOL breath score, which is just an average of each score in each of the 4 domains. And as you can see, there's clearly a negative correlation between increasing total DAS scores, so symptoms of depression and anxiety, and poor overall quality of life. So in conclusion, 37% of patients in our population had symptoms of depression, anxiety, or both. There was a small but statistically significant correlation between increased number of previous concussions and increased DAS score, which emphasizes the need for preventing concussions. And then also patients with an increased DAS score reported poor quality of life. And we found that the WHO QOL breath is an important measure that should be adopted in PCS populations. So some limitations of this study were that obviously all the patients came from one center and were diagnosed with PCS by one specialist. The expected and observed frequencies between the respondent and the total eligible population differed for mechanism of concussion and number of previous concussions. There was a response bias towards patients who did not recover. And there was also a low response rate from patients with motor vehicle collision injuries, and this is due to the fact that most of them were excluded in the preliminary exclusions due to their involvement in litigation. And also an older age bias. As I said, the mean age for our population was 39 years old. So future research should focus on the link between depression, anxiety, and quality of life. And also this will help us better understand the trajectory of recovery for each patient, and also how we can implement treatment strategies that focus on different facets of quality of life in order to help patients reintegrate back into daily life. Thank you.
Oops, sorry. We have time for a quick question. Go ahead.
So the patients who had a prior history of depression and anxiety population, we don't know how it was measured. It was just in their clinical chart that they did have one. But there wasn't, I think there was around 9 patients who actually did have a previous history of depression and anxiety out of the 105. But it was actually interesting because when you looked back at their scores on the DAS, some of them actually didn't endorse symptoms of depression and anxiety in our questionnaire, and some of them still did. So, yeah.